Okay, so we're going to continue lecture number 6 on nicotine. We just talked about caffeine. Now we'll talk about nicotine, which is, of course, another legal yet commonly used psychoactive substance. Well, we'll first talk a little bit about nicotine epidemiology, a little bit about the history of nicotine, talk about its pharmacokinetics, its mechanism of action, talk about toxicity and dependence, and then talk some about smoking cessation and potential treatment for nicotine dependence. We'll finally wrap up with a brief discussion on e-cigarette use and harm prevention. So let's start by talking about nicotine epidemiology. It's one of the 3 most widely used psychoactive drugs. It's the most preventable cause of disease and premature death across the world. Current use in the United States fell from 50% in 1965 to 25% in 1998. We're now about under 10%. The average starting age for people is declining. 9 out of 10 people are addicted by age 21. So that's the biggest problem we have, is dealing with the age at which we have onset of nicotine use. But you can see from the top graph from the CDC, lung cancer, coronary heart disease, chronic pulmonary disease are the major health side effects from tobacco use. Taking a look at the history of nicotine, no society that has ever adopted tobacco use has ever given it up. Once it's introduced, people become addicted and they constantly use it. It's the only drug of abuse that is native to the Americas. Tobacco was used as a 2-pronged tube used by natives of Central America to take snuff, used from Paraguay to Quebec. It's widely speculated that tobacco has been cultivated in the Americas since 6000 BC. It's given to Columbus when he landed at San Salvador in October of 1492. And here on out is where we start to get the spread of tobacco use throughout Europe. So it was introduced by Jean Nicot, who was first sent tobacco seeds from Portugal to Paris in 1550, and he actively promoted its medicinal use. Ironically, he claimed that lung ailments could be cured by tobacco. Within a decade of Nicot's seeds' arrival in France, the plant had made its way to England and quickly thereafter to Virginia and other New World locales. Nicotine was first isolated in 1828, and its molecular formula was established in 1843. In 1903, nicotine was first successfully synthesized by a Swiss professor of chemistry in Geneva. So, pretty rapid introduction to the old world of Europe, spreads quickly to the New World, and of course, I don't have to tell you the massive role that tobacco played in the development of the United States, the southern United States, the slave trade, and of course the Civil War. Tobacco was a substantial agricultural product in the South, really up until about the turn of the 21st century. When we finally start to get reductions in tobacco use, farmers getting paid to switch crops to try to get fewer cigarettes available on the market. So how does nicotine work? Well, nicotine was again separated out from tobacco, about 1 out of 4,000 compounds released by the burning of tobacco. It's a colorless volatile liquid. It's an alkaloid. It's not well absorbed from the digestive tract, although a number of children poison themselves each year from eating tobacco from exposure to pesticides. So one of the biggest problems associated with tobacco is its pesticide applications. The amount of nicotine delivered really depends on how the cigarette is smoked and what kind of cigarette is actually smoked. This is one of the biggest problems with trying to replace nicotine in people who smoke, because it's a very ritualized, very specific dose. Nicotine has a very narrow point at which it is pleasant to smoke. Too much and you get nauseous and dizzy very quickly. Too little, and it doesn't satisfy your craving. Nicotine is metabolized by the hepatic enzyme cytochrome P2A6, which may be inhibited by some SSRI antidepressants. So I want to be very careful by combining nicotine with antidepressants. If you look at the overall nicotine yield, you can see nicotine yields have gone up over the years, and so are actually more and more addictive. If you look at mentholated cigarettes. They have higher levels of nicotine, and there is some evidence that menthol combines with nicotine to alter its pharmacokinetic properties. And in fact, menthol cigarettes have been developed specifically to appeal towards certain ethnic groups' tastes, and there is some evidence of targeting those ethnic groups. So nicotine can be absorbed from every site on or in the body. Cigarettes are made from flue-cured tobacco, which makes an acidic smoke that reduces absorption from the mouth. So nicotine must be inhaled from the lungs, where its pH has no effect on absorption. Nicotine is suspended in cigarette smoke in the form of minute particles, or tars, and is quickly absorbed into the bloodstream from the lungs. Pipe and cigar tobacco are air-cured, and this makes an alkaline smoke, so that nicotine can be absorbed from the mouth and does not need to be inhaled. That's the biggest difference between cigarettes and pipe and cigar tobacco, is cigarettes are inhaled, pipe and cigar tobacco are not. Nicotine is quickly and thoroughly distributed in the body to the brain, placenta, and all bodily fluids, including breast milk. The liver metabolizes about 80 to 90% of nicotine before it's excreted by the kidneys. Its elimination half-life is approximately 2 hours. The major metabolite of nicotine is cotinine, and this is one of the bases for testing to see if somebody has been smoking. Oftentimes, insurance companies who will offer lower rates for non-smokers will verify that through a urinary cotinine test. For smokers, carbon monoxide is also detectable in their breath for hours after their last cigarette. In fact, I have conducted research on nicotine withdrawal, and we use a carbon monoxide breathalyzer to detect whether or not they have been smoking recently. So these are a variety of components contained in a cigarette. Lots of different components that come out of a cigarette, including potentially arsenic, carbon monoxide, methanol, hexamine, toluene, nicotine, ammonia. Lots of things that aren't particularly healthy for you. How does nicotine work? Well, it has an indirect activation of the sympathetic nervous system. It occupies and activates the nicotinic cholinergic sites. Remember, there are nicotinic and muscarinic acetylcholine receptor sites. So it occupies and activates the nicotinic cholinergic sites. Low doses stimulate those receptors. High doses will actually block the receptors. High doses of neonicotinoids are the basis of a lot of pesticides. So nicotine and pesticides are highly related. This causes the release of this stimulation of the receptor causes the release of dopamine, which may be related to the reinforcing effects of nicotine. Also causes the release of acetylcholine and glutamate. Nicotine has been tied with memory performance. It's once thought that perhaps we could provide nicotine supplementation to older adults to improve their memory, and that has not panned out, because by the time you give someone enough nicotine to improve their memory, they have a tendency to become dizzy and nauseous. So question is, would nicotine-derived drugs help dementia? Well, there is limited evidence that that has been the case, but there is ongoing research to try to determine whether some sort of neonicotinoid might benefit dementia patients by increasing acetylcholine. So nicotine attaches to nerve cells in the brain at receptors on the cell membrane. So if you see there are nicotinic acetylcholine receptors, they stimulate neurotransmission, so it's entirely possible that you might be able to get some sort of beneficial memory effect from some sort of neonicotinoid. In terms of pharmacological effects of nicotine, it initially causes nausea and vomiting by stimulating the vomiting center in the brainstem and sensory endings in the stomach. People who continue smoking become tolerant to these effects, and they no longer notice them. Stimulates the hypothalamus to produce antidiuretic hormone, which can cause fluid retention. Reduces activity coming in from the muscles, producing relaxation. This is one of the paradoxical effects of nicotine. Is it's technically anxiogenic. That is, it increases neural activity and should cause anxiety, but people says it relaxes them, and it seems to be due to this muscle relaxing activity. Also increases your heart rate, blood pressure, and contractility. But carbon monoxide in smoke combines with oxygen better than hemoglobin, so it decreases oxygen carrying capacity and actually suffocates cells. So some major combination effects derived from smoking cigarettes. Nicotine also constricts the blood vessels in your skin, producing cold, thin skin. It also causes your skin to wrinkle faster. It inhibits stomach secretion and stimulates bowel movement, so it actually, in a non-tolerant person, will function as a laxative. May increase metabolism of fat. This is one of the problems with trying to get people off nicotine, is oftentimes they will gain weight and they find that intolerable, and so will go back to smoking. One big problem with people who smoke is it does dull their taste buds. Smoking slows stomach contractions and increases blood sugar. Again, nicotine may improve attention and memory, although certainly high doses cause increases in nervousness, tremors, can even cause seizures and panic attacks. So while it is associated with improvements in attention and memory, it's difficult to foresee a way in which you can dose this right to make it a good memory enhancer. There is a chance that nicotine has some antidepressant effects, and there's some question about whether or not smokers are self-medicating to try to treat their depression. Maybe some of them are, but so many people start smoking at such a young age that it seems unlikely to me. Another note under the mechanism of action is Nesbitt's paradox. As I was saying earlier, there is a little bit of a paradox in terms of how nicotine affects people. It causes arousal and release of epinephrine, which should be anxiogenic. Yet most people say it relaxes them, and this may be relevant to the reason why people smoke. A couple of questions about why this might be. Is it simply relief from withdrawal? That is, do people relax because it eases their anxiety about the fact that they haven't been smoking? Does it depend on the situation? Do they get relaxation with high stress and stimulation with low stress? It's really unclear, but there certainly is something situational. And certainly smokers report positive subjective effects if nicotine is given by smoking or intravenously, but non-smokers absolutely do not like nicotine. So there is something to the individual differences in people who have become tolerant to its effects. We're starting to understand, too, that there is a genetic component to propensity for nicotine addiction. That is, those nicotinic receptors are different in certain genotypes. And so it's something we'll talk more about later on in the semester. So why does nicotine and why does smoking in particular cause such damage? Well, nicotine can cause a certain amount of toxicity. Nicotine increases the workload of the heart. Carbon monoxide decreases the oxygen supply, reduces the lungs' ability to get oxygen, which may make the heart work even harder. It's known to increase arterial sclerosis, which is, of course, blocking of the arteries, and thrombosis. That is, it increases the risk for blood clots, particularly in women who are taking birth control. So if you take an oral contraceptive, smoking in combination with that puts you at really significant risk for stroke. Obviously, one of the most significant effects of smoking is lung disease. My father died of lung cancer. He was a lifetime smoker. Ash and tar, which are deposited in the membranes of the lung. This reduces the action of the cilia and phagocytes that would normally clean these tissues, and as a result, the lungs can get pretty gunked up. You can tell pretty clearly somebody who smokes quite a bit based on their hacking cough. So this is what a healthy lung looks like here on the left. In the middle is a diseased lung from smoking. So there's certainly an increased risk of cancer of the lungs, mouth, and bladder. This is greatly increased by alcohol. Less than 10% of non-smokers get lung cancer, so this really is directly associated with smoking. Another problem or complication associated with smoking is reduced oxygen delivery to a fetus. It decreases fertility in both males and females, produces smaller babies, more stillbirths, premature babies, and sick babies, and may increase the risk for sudden infant death syndrome. One thing we know is people can develop tolerance to some of the effects of nicotine, as we've already discussed, and we certainly know many people can become dependent on nicotine. There's little biological tolerance. Smokers usually dose themselves with very consistent amounts. Withdrawal symptoms from nicotine include irritability, anxiety, anger, difficulty in concentrating, restlessness, weight gain, and insomnia. Long-term nicotine use causes an alteration in GABA systems in the hippocampus. Because nicotine inhibits GABA, removal of nicotine during withdrawal causes increased GABA activation. And we have shown, because of this increased GABA activation during withdrawal, heavy smokers show marked reductions in memory performance following 24 hours of abstinence. And this is a fairly clear finding. We have found it in 3 different research papers, and others have found the same finding throughout the literature. In one paper we found there may be some sex differences in the cognitive effects of withdrawal, and certainly we know that there are differences in how men and women respond to different kinds of treatment. So quitting smoking is obviously something most everyone should consider. So when you stop smoking, your body begins to repair itself almost immediately. Within 20 minutes, your blood pressure returns to normal and your heartbeat will stabilize. Within 8 hours, the oxygen level in your blood will increase. Mucus begins to clear out of your lungs, making it easier to breathe. Within 48 hours, you'll start to get your sense of smell and taste back. Your chances of heart attack will start to decrease. Within 3 months, you get improved circulation and immune system responses. Within 9 months, sinus congestion, wheezing, shortness of breath, and phlegm production decrease. Lung function improves. Within a year, you get the risk of dying of a heart attack is cut in half. 5 years, your risk of a stroke is back to that of being a non-smoker, and after 10 years, your risk of lung cancer is cut in half. So lots of positive effects from quitting smoking. So how do we go about doing this? Well, various therapies. Low content, no nicotine content cigarettes appear to be not a helpful way to get people to quit smoking. They just smoke more of them, causing more harm. Substitution or replacement of nicotine by things like Nicorette gum, nicotine patches, nasal sprays, and inhalers are difficult because trying to match the dosage of nicotine is very difficult. People are very expert at their ability to get the exact right of nicotine when they smoke. They inhale a certain amount, they hold it in for a certain amount of time, they smoke the same brand of cigarettes all the time, and so they are really good at regulating their own nicotine content. And so trying to replace that with some other way is very difficult. There are potential efforts to reduce simple craving. So some antidepressants, particularly those that involve the dopaminergic system, are particularly effective. So bupropion, which is Buspar, or Zyban, which is Wellbutrin, have some efficacy in reducing craving. All replacement methods are equally effective, approximately doubling the quit rate of smokers without any other kind of help. About 90% of smokers stop without help. Deciding which is the most relevant factor in smoking: pharmacological addiction, there's sensory motor addiction, and the cognitive effects of withdrawal, social factors, and decreasing with prohibition. So trying to figure out which is the most relevant factor to get people to stop smoking. Obviously the pharmacological addiction is a big part of that. There are a lot of sensory motor cues associated with smoking, so there is kind of this stimulus response effect. And this seems to be particularly salient in women. That is, they respond much more to smoking cues and tend to be more social smokers. And so that's where we start to get into social factors. Decreasing smoking with prohibitions is certainly been effective by prohibiting smoking in public areas. One of the most effective ways to decrease smoking is by increasing tax rates on cigarettes. In fact, we call these so-called sin taxes. I believe it's more of an economic externality by recouping the cost of smoking through increased taxes. So factors that create the addiction for people who smoke: about 10 to 15% of current alcohol drinkers are considered problem drinkers, but about 85 to 90% of cigarette smokers consider themselves addicted to nicotine, so highly addictive. You get very rapid and frequent reinforcement. So for every pack of cigarettes, you get 200 reinforcements. You get rapid metabolism, so that clearance allows for frequent and repeated use, plus this rapid onset of withdrawal. These complex direct pharmacological effects and social rewards of the peer group, although that's certainly changed. Smoking is now almost more of a stigma than it is anything else. And smoking can sometimes be conditioned to other activities. Some people say they like to eat and smoke, which I find perplexing. I just can't imagine eating and smoking at the same time. But certainly I've seen plenty of people who are social smokers, people who just smoke at the end of the day, people who smoke a lot when they drive. And so there is this sort of stimulus-response relationship between these effects. So other factors that create this potential for addiction, there's no performance impairment with smoking. In fact, there may be even improvement in alertness and reaction time for people who use nicotine. Used to be relatively inexpensive. I think at this point, keeping a smoking habit's probably not that far away from a cocaine habit. It doesn't require any specialized equipment. You don't need a needle or a bong or anything. You just need a lighter. And it's readily available. You know, any convenience store really is where you can find cigarettes. And of course, it's portable and easy to store. And so all of these things make it much easier for people to get at their nicotine. And of course, it's legal for ages 18 and up, although in California this just changed to 21 and up. How do we treat nicotine dependence? Well, pharmacotherapy is the primary alternative for treating nicotine dependence. We, of course, have nicotine replacement therapy through gums, patches, even inhalers. Bupropion, which is, again, Wellbutrin or Zyban, is another potential treatment. And finally, we have the partial nicotinic receptor agonist varenicline, which is marketed under the brand name Chantix. And this has been demonstrated to be very effective in treating nicotine dependence. Unfortunately, not everyone responds well to varenicline. In fact, when we get to talking about pharmacogenetics and pharmacogenomics, we'll take a look at the problem of people who are what we call hardened smokers, who have a different genetic makeup, who don't respond to varenicline. In conjunction with pharmacotherapies, some specific cognitive behavioral therapies often work. So a specific quit date might be set. So one of the things we often have is no substantial social occupational dysfunction, so that makes it easier to do. There's less need for family involvement. And there are effective over-the-counter treatments available. Varenicline is by prescription only, but most nicotine replacement can be taken over-the-counter. In terms of assessing how dependent someone is, we can use a number of measures, the number of cigarettes per day. There is the Fagerstrom test of nicotine dependence, which tests a variety of issues with nicotine dependence. If you score less than 3, there is low to no nicotine dependence. Greater than 6 is considered highly dependent. You can also measure nicotine and cotinine levels in blood, saliva, and urine. Nicotine use can be detected within hours. Cotinine reflects tobacco use in the last 7 days. And carbon monoxide breath analysis in the last few hours. Nicotine replacement therapies can be used as a first line of treatment. There are 5 FDA-approved nicotine replacement therapies. These include patches, gums, lozenges, nasal sprays, and inhalers. The difficulty here is in matching the dosage. We're going to talk about e-cigarettes or vaping later, but it's a potential way to replace one form of nicotine with another that may potentially be less harmful. The evidence is still out on that, but we'll talk more about that here in just a moment. But you can combine nicotine replacement therapies, or you can combine nicotine replacement therapy with bupropion, and that seems to be effective. So bupropion, again, can also be used as a first-line treatment. Target dose is about 300 milligrams per day. Start at 150 milligrams per day, 7 days prior to the quit date. After 3 to 4 days, you increase your dose to 300 milligrams by taking it twice a day. Side effects include jitteriness, insomnia, and potentially some GI symptoms. There is the risk for seizure. Definitely not something that should be used in anyone with any sort of eating disorder. So that's something to keep in mind. Varenicline, or Chantix, was approved in 2006. It is a unique monoamine oxidase inhibitor and is a partial agonist at the nicotinic acetylcholine receptors. It blocks the ability of nicotine to stimulate the acetylcholine receptors, thus blocking activation of dopamine. Its elimination half-life is about 24 hours, which makes it almost perfect for taking once a day. People who take varenicline start taking it and smoke and just gradually reduce their cigarette use, and because they're no longer getting any reward from that cigarette use, it completely disconnects their reward from cigarette smoking. So dosing is usually after meals and with a full glass of water. Recommended dose of Chantix is 1 milligram twice a day, following a 1-week titration as follows. Days 1 through 3, half a milligram daily. Days 4 through 7, half a milligram twice a day. Days 8 through the end, 1 milligram twice a day. Course of treatment is usually 12 weeks, plus then another 12 weeks if they've managed to stay abstinent. The most common side effect of varenicline is nausea. But here's how it looks out. If you look at continuous abstinence, after 9 to 12 weeks, varenicline has the highest success rate. Placebo, of course, the lowest success rate, but some people do manage to stay abstinent with no help. We go to weeks 9 through 24. Again, still get the best results with varenicline, and even out to a year later. Much better results from varenicline. About 25% manage to obtain continuous abstinence if they quit with varenicline. Again, just some data showing various dosing regimens comparing to bupropion. This is manufacturing data from the manufacturer, so you want to always take that with a dose of skepticism, but does demonstrate efficacy. Final thing I want to talk about with nicotine is e-cigarette use. A principal component of drug treatment is this idea of what we call harm reduction. And we're going to talk quite a bit about this when we get to discussing opioids and how to potentially reduce the harm from opioid addiction. So e-cigarettes have been shown to be less harmful than traditional cigarettes, but they are still more harmful than quitting altogether. So some studies have shown a high oxidative stress on lung tissue and some potentially harmful components. The other issue with vaping is the nicotine dose is much lower. So people tend to have to inhale a lot more to try to get the same dose as their cigarettes. So oftentimes there's some concern about that high oxidative stress and, again, these potentially harmful components. But again, if we're talking about relative harm, e-cigarettes are much better than standard tobacco cigarettes. And it's easier for people to match that nicotine dose and potentially reduce their nicotine usage by switching to vaping. So e-cigarettes have been shown to provide an appropriate nicotine replacement therapy and can lead to total cessation. The biggest problem currently with use of e-cigarettes is kids. FDA just moved to regulate e-cigarettes in May, requiring only sales to those over 18. Most jurisdictions already have that, but not all. But as you can see, about 14% of 10th graders have been using e-cigarettes compared to 7% of conventional cigarettes. So we really want to try to not have a new generation of kids that are addicted to nicotine by vaping. So while vaping is good for someone to transition from tobacco to, we certainly want to keep people from starting on nicotine with vaping. Well, thank you, and that's all of our discussion of nicotine. I hope you found it interesting.